I'm going to start with these. I have a couple questions about rifampicin here, which I'm not going to read out loud, but the study is ongoing at a bunch of sites in the country. The closest site to here, I think, is New York. It is actively going on. It is not recruiting new patients right now. I do not know of any preliminary results. They will not reveal any preliminary results until the study is finished enrollment and all of the data are analyzed. So there is nothing published about that yet. And the fact that they do more than one study with a compound even before other study results are released doesn't tell you that the compound works or not. It just may be looking at trying to answer different questions, like whether a certain dose is tolerated versus whether a certain dose is effective. So I don't have any information about that other than there are trials going on and that nothing is recruiting right this second.
Always forget to give this 2 seconds to warm up. I think we have a question here from the floor.
I'm sorry, I'm going to probably be just clarifying what you had just said. So, I mean, your slide was from 2008, I believe. Maybe that was the problem. But the study, my husband was in it for a year, and he's already done. We were still waiting for results. So is there a new study coming out, you're saying? There is another study?
There is a study that is actively going on right now.
Yes.
But it is not recruiting new patients right now.
Okay, I know that my husband completed that study for a year, but when you were asked, then you said there's a new study. Was it just a mistake, which is fine? I just want to make sure.
That's going to start. I think there is another study planned to start, but I don't know when that is going to be.
Because it's not on clinicaltrials.gov. We just check now even to see. I just don't want any misinformation. I understood later when you clarified, but when you were talking, I was actually shaking. I'm like, how does they not know this study? He's already done it for a year, and we're waiting for results. I just wanted to be sure. So we don't know if there's a new study, and that one we're waiting for the results from.
Exactly.
Okay. And one thing didn't come up in clinical studies. Some places, just so everyone is aware, you have to pay, and some places you don't. And that's just how it is. So we were in that study in New York, $1,700 to get evaluated, and you may or may not get in, while in other parts of the country, it was free. So just be aware of that when you're going to look at studies.
Thank you.
I just want to let you know I am in the study. I've been on it since April 4th, 2011. And I should be ending soon. I see the doctor at the end of the month.
Thank you. Back up to the front table then for the next question.
Okay. Great question. How do you feel about the Vibram 5-finger shoes? Does everybody know what that is? Have you seen them? So it's a sneaker that literally fits the foot. So each toe goes into a slot. I see people wearing them in the city, and I absolutely cringe. I'm like, oh, God, what if you step on glass? No, they have a rubber bottom. Yes, they are a minimalistic shoe, but you have to have really strong ankles, and with decreased flexibility in the ankle, it may not be the best fit. Something you would want to talk with the PT about. Would it be something that we would recommend? Because does the fact that they have no heel make a patient stand straighter? Well, realize everything's connected, so if you have a tight calf and heel cord, so if you typically have tight hamstrings and heel cord and you have a sneaker with a high heel, if you bring your heel to the ground, it can cause you to lose your balance. It all depends on flexibility. In theory, yes, if your heels are on the ground, yeah, you would be straighter if you have proper length of hamstring, okay? But great question. I haven't recommended them for anybody. You really have to have strong ankles and good flexibility for use. But it's an interesting thing to see people wear.
Okay, doctors, I have one question over here that we're going to answer.
Okay.
What's the question?
Okay, the first question is where is a way to donate online?
So on the shydraeger website, which is at shy-draeger.org, on actually on every page in the upper banner in the right-hand side, there's a link to make a donation through PayPal. And there's also a donate to Shydraeger page on the website where you can get an address to make donations.
And then the other question is, where can I donate to MSA Research?
So over the last few years, after we got the PayPal and our 501c3 set up in 2004, we actually started raising enough money where we could support these types of meetings and our educational initiatives, but also had money left over that we wanted to start participating in research. So we've actually been able to, right now, a minimum of 75% of all donations go into a research fund that we've developed, and we're starting to accumulate enough money to begin supporting some substantial research initiatives. Starting 3 years ago with the American Autonomic Society in partnership with them, we provide travel grants to fellows that are attending the American Autonomic Society for the best research abstracts that are presented for MSA. So we do anywhere from 1 to 3 of those sponsorships each year. And I believe beginning next year, we're going to start supporting fellowships. So when a physician, a medical student is interested in studying more in the MSA area, they'll be able to provide a proposal to us where in that proposal they would have to detail some of the research that they would like to do in multiple system atrophy. And based on the best applications that we get, we would probably support 1 to 2 fellowships per year. And in talking to the physicians that specialize in this area, we believe that that's the most effective way for us to start generating positive research around the possible causes for multiple system atrophy and hopefully someday a cure.
Okay, and the last question I have, and I'll have to answer it, is how do we acquire those awesome Cure MSA shirts? Lily Shea, she lives in Northern California. Her mother passed away from this a few years back, and she's the one that has them. She usually has them during the fundraiser MSA awareness in March and then October. She has a Facebook page. You would have to go on there and find her, or I can go and put the link on our SDS MSA support group Facebook page where you can contact her. But that's how you would get them, if you know. And it's just every 6 months that she puts them out. So, okay, thank you.
I have 2 questions here, both about drooling, which I can address. Any tips that we have for excess drooling, and is this something that happens with MSA? Yes, drooling is something that we commonly see. And there are some tips that I can give. Number one, the reason why most people drool is because they're sitting with an open mouth posture, and so they're sitting with their mouth open, kind of like this. When that happens, you have a hole in the system, and so that saliva is going to go the path of least resistance. The one thing I will tell you is sometimes people think they have excess saliva or too much saliva. You're not producing any more saliva than anybody else in the room. It's just that you're not swallowing it as effectively. And so if you're sitting with an open mouth posture, you lose the sensation of what's going on in your mouth. Your body doesn't have that sensory awareness to go ahead and swallow the saliva that's forming there. So a couple things I do is always take note of what your posture of your mouth is like when that's happening. Be more aware. There are some exercises you can do, kind of rubbing your lips together like you're putting chapstick on, or rubbing your teeth, your tongue behind your teeth to just kind of be more aware of what's going on in your mouth. Chewing gum could be a great way to kind of be more aware because you're going to be moving your tongue and your mouth and your lips around, so that will increase the awareness of it. If those things do not work, you can talk to your doctor, and there are some pharmacologic medications that could be recommended to reduce saliva, but that could have side effects for constipation as well. So it kind of becomes a fine line, because we're trying to dry you out to reduce the saliva, but we don't want to dry you out and make more constipation if that's already an issue. So, set timers like Joellen was saying. If you're watching television, every time a commercial comes on, make that your cue to kind of be more aware of what your mouth is doing, run your tongue behind your teeth, those kinds of things.
I'm going to jump to this question about Botox use in MSA because I think it's relevant to the drooling. We do sometimes use botulinum toxin injections for drooling because the oral medicines that can dry up your mouth do have other side effects in terms of bladder, constipation, thinking, so that Botox can be injected directly into the salivary glands and actually stop the release of saliva so that your mouth is not as moist and you don't have as much trouble with drooling. Botox injections typically last for about 3 months, so you have to have them repeatedly done, but it's not a big deal. It's done in the office and only takes a couple minutes. The other thing that Botox is useful for, in addition to the bladder stuff that we talked about this morning, is eye-opening apraxia, that sometimes people have trouble opening their eyes. It's not that their eye muscles are weak, but they close and they have to sort of physically lift up their eyelids to keep their eyes open. And the Botox can be injected into the eyelids to try and stop the muscles from closing your eye so that you have an easier time keeping your eyes open and seeing with MSA.
I had a question on bed rails. MSA patients should use bed rails which go to the floor, and other bed rails, is there potential risk of flipping of the mattress? So yes, there are a ton of bed rails on the market, and not everyone is appropriate for every mattress, depending on the size of the mattress, depending on your weight, depending on the level of motion which you have in the shoulder. All different things therapists think of when recommending a specific device. There are bed rails that do attach all the way to the ground, so go ground actually to ceiling like an actual pole. There are bed rails, again, of different widths that secure differently to the bed. There are some that are actually to the frame of the bed on the bottom screwed in, so they're not going in between box spring and mattress where, you know, the thought of is flipping. There's also different devices, so say a bed rail is not something needed because the patient is more concerned with repositioning. There's actually something called a bed ladder, which almost looks like a non-rigid ladder, almost like a yoga strap used for stretching, which is attached at the base of the bed frame and drilled in, and the patient can keep it under the covers and utilize that to pull from and reposition shoulders or upper body. So there's different equipment out there. And yep, that's the role of the therapist to say, hey, based on the setup in your room and your needs, this is what I think is best for you. There isn't one that's universal. The one pictured above is not what is to be used for everyone because everybody's different.
Another kind of on the other side of drooling is a question about dry mouth. For the side effects of medications can cause dry mouth. There are products available. Biotene uses toothpaste and mouthwash, lozenges that you can use. There's been recent studies about the use of papaya to increase salivary production in patients post radiation therapy for head and neck cancer. They've been using that a little bit more. So certainly the strips of papaya, of dried papaya, they've been using and setting that on the tongue and in the side of the mouth to help with, to improve some saliva if you are having dry mouth. Increasing hydration is another thing, but again, that can then become tricky with the bladder problem. So depending on how severe it is, we can make recommendations on different kinds of products. But Biotene products are very good and tend to work for that.
There's a couple questions here on stem cells and sort of their differentiation. The idea of a stem cell is that it is an immature cell, so it can grow into other things. Typically, those immature cells are what are injected into the patient because part of what makes the stem cell turn into whatever it's going to turn into is its environment. And there are stuff around that scientists don't really understand. So it's not like they could put it in a dish and expose it to everything that it needs to differentiate into the type of cell that they want it to differentiate into because they don't know exactly what that cocktail is. So putting it into the environment where it will grow into the kind of cell that they want is the best way to try and get it to differentiate into that type of cell. It also has to do with the positioning of the cells within that environment. So for example, if you're looking at a heart cell that needs to grow, or an immature cell that needs to grow into a heart cell, it needs to be lined up the right way, so the heart cell is lined up the way the other heart cells are to make the heart contract the way it's supposed to contract, because those cells, they all line up in the same direction so that your heart can pump, and you don't want some growing diagonally compared to the other ones, because then when the heart tries to beat, it's not going to beat effectively. So there is a lot about that differentiation process that we really don't understand. We try to put in different kinds of neurotrophic factors or something to sort of push the cell differentiation in one direction or another, but it is not well enough understood that we can differentiate them first and then implant them. And part of doing it with brain cells in particular is that you don't just want them to turn into a brain cell, but you want them to develop connections with other brain cells, because it's the communication between brain cells that's crucial for function. And so you need to have them in the environment where they can sprout those connections to connect with the cells that they need to connect with.
Great question. Seasonal, as I spoke to with winter coming. Advice on walking in the snow and any specific recommendations with a walker in the snow. A lot of times recommendations we give for when winter comes around and you're going to be going outside, they make trekking soles which can be applied to the base of shoes, dress shoes, sneakers, and basically what it is, it's rubber and you pull it over the base of your shoe and it has little spikes on it, nothing that would puncture anything, but I wouldn't quite walk across your hardwood floor in them, but it'll give you traction. So that is what you would put on your feet. As far as the walker, obviously you'd be wanting to go over a cleared path, even though it may have ice, and again, that is a little bit of a concern where it may go away from you on that decline. People tend to slip most when descending down a driveway or ramp, rather than going forward, sidestep. You'll have better control and you won't be fighting momentum quite as much. Another thing that you can add if you're a person who uses a cane, they make cane tips that have an ice pick at the base. You buy the tip, it's universal and it can be applied to the base of all canes, so you just take off your tip and put on that, and that again will give you some traction outside. Another great tip was whether or not, tip for warmth in winter, heated mattress pad. May be great for you, may not be great for your spouse, so talk it over with the person next to you, okay? Maybe they may want you to wear the heavier pajama, but yes, that's a tip. Perfect, I didn't even know that. That's good to know. I will share that in the future. So keep that in mind too, everybody. Another good tip. Oh, they make heating mattress pads that are dual controlled. I didn't know that. So that's wonderful.
A comment somebody made about terrifying to see someone choke or choking with meals, and that they have a sign so that if they need to start the Heimlich maneuver. I think always a great idea for people to get educated on when to use a Heimlich maneuver and how to do it. The first thing I like to say to people, though, is you don't want to do a Heimlich on somebody that still has an airway. And the best way that you can tell is you'll hear them coughing. You'll hear something, or even if you hear the horrendous happening while they're choking, there's still an airway there. And if you get behind them and you're squeezing their diaphragm and trying to push things up, you're going against what their body's trying to naturally do. So if you are hearing air coming out, you should refrain from doing the Heimlich. You want to do the Heimlich when you stop hearing noise. So if it's and a deafening silence, that's when you want to do the Heimlich. That's when you want to step in to do it. But if they're coughing, let their body do what their body's trying to do. It's its own protective mechanism. And one last question for me is, where do I get a swallowing evaluation? Talk to any of your physicians. There should be a speech-language pathologist in your area that can do it in office. You can always have a swallowing study done under X-ray if there is not a speech therapist in your area. And also you can go to the website asha.org, and that is the National Foundation of Speech-Language Pathologists who are accredited in the country, and you can find somebody in your area with that specialty. Yes?
That was my question.
Oh.
And can I just add something
Sure.
Can any speech pathologist do a swallowing?
Well, hopefully they would tell you they wouldn't feel comfortable doing it.
Well, I'm just asking because I'm a teacher, so I know a lot of speech.
Oh, probably not a speech pathologist in a school. No. No.
Because just getting my mother anywhere might be.
If it's hard, then try to get a home therapist into the home. But even if it's a pediatric swallowing therapist or speech language pathologist in a school, probably very rarely sees dysphagia, and if they do, it's a pediatric dysphagia, which would be significantly different than this population.
I have a question here on brain donation for research, why they would take a skin biopsy. Your skin has nerves in it as well, and sometimes they want to look at the nerves, the peripheral nerves, as well as the brain tissue to get a sense of how the nervous system is functioning and what kind of changes have gone on in other parts of the nervous system in addition to just the brain. So sometimes they want just the brain, sometimes they want the brain and the spinal cord, sometimes they want the brain and a more peripheral piece of tissue to be able to look at the peripheral nerves as well. Am I the only one left? Yes. I am. Sorry. Okay. This one is asking about CBD and cannabis, which is it's a component of certain types of marijuana. The part that apparently doesn't get you high, but actually can have potentially some good effects on the nervous system. It's interesting, as I'm applying for my New Jersey medical license, I didn't realize that now I would be having a license in a state where I could actually prescribe marijuana for my patients, which is a new concept, but I honestly do not know of any places that are doing research on this in this country. This question says that somebody was approved for treatment in Israel, which they are.
His name is Tommy Fitzgerald. He's a very good friend of mine. He has MSA, and he's done a lot of research on it. And he's just accepted into a trial with these Israeli doctors that have been doing this for a long, long time. They found some great benefits in it. He's been accepted for the trial. Now they're just waiting to see if the U.S. government will let them bring this stuff into him. So his question to you was, are they doing this here? And you just answered that question that they're not doing this here, but could you call him? He would have not I would really like this man.
They are looking at this kind of compound for the treatment of spasticity, so in multiple sclerosis for increased muscle tone. There is also a thought that it may have some effects on inflammation, so that for different infections or different inflammatory conditions it may be useful. But I don't know of anything going on here for MSA per se.
Okay, another question. In Canada, we have the medical marijuana. We have the medical marijuana. So it's no problem. People can go to the doctor, get the prescription. Can you do that for him?
Can
you prescribe medical marijuana to him?
I think that you have to be, it's very regulated here. There are ways that you can prescribe medical marijuana only in certain states, and I think that the person has to be a resident of that state for you to do it. I don't think that when I worked in Pennsylvania, even if medical marijuana is legal in New Jersey, I can't write somebody a prescription and send them to that other state to go pick that up.
Okay, if you could call him, be great.
And then there's a question. These questions are great questions, but I don't know the answer to some of them. If you can donate unused embryos that are saved from prior IVF for research. And I am not sure if you can do that specifically, unless you know some who is doing embryonic research for MSA that would be looking for tissue, but I'm not sure how that would be done. research on nutritional supplements, vitamins, fish oil, diet in MSA. There is a lot of interest in what I would say are more natural remedies for different conditions, but there are no clinical trials going on right now looking at specific diets or fish oil or vitamins or nutritional supplements specifically for MSA. And then this question has to do with somebody who had a head injury due to a fall, who also had MSA, and how the recovery is delayed. When you have a neurodegenerative condition, doesn't matter what it is, whether it's Parkinson's, whether it's Huntington's, whether it's MSA, whether it's multiple sclerosis, when you have an additional stress on your body, so you fall down, you break your hip, you fall down, you hit your head, something else goes on, you get a case of shingles, it's some other stressor on the body, whether it's medical stress, whether it's emotional stress, your symptoms of that underlying condition are going to seem to get dramatically worse. And it's going to take you much longer to bounce back from whatever that additional stressor is than it would have if you didn't have the MSA or whatever the underlying condition is. So definitely the fact that you have MSA when something else happens is going to delay your recovery. And depending on what kind of an issue it is, if it's something like a head trauma where you may have weakness or trouble walking because of the head injury, and you also already had trouble walking because of the MSA, then it's going to make that recovery even harder, because it's going to be hard to know how much bouncing back you can do, because you aren't going to get back to normal. You may get back to close to what you were before, but the MSA is continuing to progress while you're recovering from the other thing. So it is hard to sort out, but definitely having an underlying condition is going to slow down the recovery process and definitely impact on the recovery process. But that doesn't mean that you shouldn't aggressively try to get back to where you were after you have an additional stress. So how, this other question is, how can the medical community educate other physicians and professionals about MSA? Well, hopefully we do that at meetings. There are typically posters and presentations about conditions like MSA. There are publications about MSA. When we are at work in the hospital teaching residents, we have them read articles about different conditions. We have them rotate through movement disorder centers so that they can learn about MSA and see patients about MSA from doctors that are comfortable treating it and diagnosing it so that they know what it is. So I think that's how we do this. We go out to different rehab centers, other healthcare professionals, to try and educate them about MSA so that we can help them know how to better treat those conditions. And then other people, other healthcare providers, physical therapists, occupational therapists, speech therapists go out and teach other speech therapists, like the program that Marissa was talking about, the LSVT for speech, that has been expanded to not just Parkinson's disease, but to other conditions. And they go out and train other providers to be able to use that technique with their patients. So I think that there is a lot going on in that sense, that they're within the medical community trying to improve education. And there are definitely lots of symposia that take place during the year, both in this country and abroad, that help to educate physicians and other healthcare providers.
I just have a quick question. I actually asked the question about the head injury. My mom actually had a severe head injury a little while ago. She's going into rehab right now, and we're more concerned with, there's obviously things that the doctors don't know about MSA. They don't know exactly how it's affecting her recovery, and I understand, you mentioned things about the dysphagia, and there's, the lower voice. Now, these are things that we're finding with my mom. We don't necessarily know if it was because of, she had a breathing tube at one point, she had a feeding tube at one point. So her throat's obviously gone through a significant amount of abuse as well. So obviously these are things, I guess, that time will tell. But as far as recovery is concerned, do you know if there's any research on whether injuries like this have made MSA more aggressive, or can we expect that potentially this would have affected her MSA at all? Not just that the MSA is affecting her recovery, but that her recovery or this injury will make her MSA more severe.
The injury is not going to change the MSA,
okay.
But the injury is it's hard to say. I mean, the MSA is affecting her brain. The injury is affecting her brain, so her brain is more damaged than it was from just the MSA. Right. And it's hard to know, how much of that will bounce back. But having something else happen it doesn't make the MSA progress faster, okay. If that makes sense.
Yeah, no, that's fine, and that's good. Thank you.
And then the last question is there anything that helps shortness of breath symptoms, tightness in the diaphragm, the feeling of not getting air into the lungs? It can depend on how severe that is. Sometimes breathing exercises, really trying to strengthen your diaphragm. Sometimes it's from actual tightness in the chest muscle, that is from the increased tone, that is from the MSA. So sometimes medicines, the muscle relaxing medicines, will help to relax those muscles and allow you to expand your chest a little bit better. Sometimes anti-anxiety medicines will help, which sometimes they're muscle relaxers as well. If there really is sort of upper airway restriction that makes it hard to breathe, then sometimes doing a trach and actually opening up the airway lower down so that oxygen can be exchanged and air can go in and out without having to deal with any kind of spasms in the upper airway that would impact on the breathing. Sometimes we use, it sounds sort of the opposite of what you would think, but sometimes we use narcotics because they will stop that feeling of sort of air hunger, like I just can't get enough air into my lungs, and they will relax you, but they can be sedating. They can also depress your drive to breathe, so that isn't typically the first thing that we would pick, but there are medicines, there are different techniques that may be able to help with that sensation, so you should talk to your doctor. Any other questions?
Here you go.
Can you speak? Is there? My wife has speech delay as well as all the other speech issues, and I'm just wondering if that's typical of MSA, and if there's any sort of history of ways to address that.
I'm not sure what you mean by speech delay. Do you mean difficulty finding words?
No, she knows what the words are. There's a delay in getting something out. Very slow response.
Like slowed thinking? It takes her a while to get her...
I don't think it's slow. No, she doesn't say slow thinking. It's just takes a long, long time to say what she's thinking. So, for instance, when she picks up a telephone, it might be 10 seconds before she says hello, even though she knows she wants to say hello.
I think that would probably be something that would have to be evaluated further with some standardized testing to make sure that cognitive function is intact and that there, Dr. Coulter talked about eyelid apraxia. I don't know if verbal apraxia is something that could be something with MSA, but apraxia is a motor function problem where you know what you want to say, but you can't make the muscles of your mouth actually say that. So we could do some tests to see if we're finding verbal apraxia as a result. So I wish I could give you a better answer, but I think it would have to be evaluated a little bit more.
But it's not really typical of MSA specific.
It really depends on what we find out to be the issue.
Okay, Can you talk really loud, Tony, since you're that far back? So it gets on the
Question is
video.
whether there are clinical trials in Canada or whether Canadians qualify for U.S. trials. Definitely you can travel to another location to participate in a clinical trial. So it doesn't matter because typically the first visit with the doctor, like if the doctor doesn't know you and you want to be part of a clinical trial, the first visit may be a new patient visit that you would have to pay for because you need to see if you qualify, and they can't always do that over the phone or from reviewing your medical records. But then if you did qualify for the clinical trial, most of those clinical trials did not have to pay for participation. The care should be free, and all the testing should be free. A lot of the sites that participate in clinical trials are North American sites, so there are plenty of good movement disorder programs in Canada that participate in clinical trials with other people. Like the MSA study group, it's North American, it's not just US. So there are people in Canada that do that as well. So I think looking on those kinds of websites, and it will list the sites that are participating in those clinical trials, and you can see if there's something in Toronto or there's something in Montreal or a place that's really known for research in movement disorders.
Okay, I think that about does it. I've got to, first of all, thank you so very much for coming. It has just been, and if we could afford to pay them, there'd be millionaires on leaving tonight. But unfortunately, we are just so grateful for your volunteering your entire day to be here with us and staying to answer the questions. Before we break, I want to remind you all to fill out those evaluations. Normally, we have breakout sessions where the patients who want to come kind of get in one side of the room, which would be in the back, and the caregivers would kind of be up here and discuss issues that you may not feel comfortable discussing with your loved one. You might want to say, I hate the way her hair looks every morning, and, and the wife might be in the caregiver thing saying, I hate the way his hair looks every morning, but you never just kind of discuss that. But so we might give you some tips, but you might have questions that you really want to just discuss as a patient or a caregiver without the other one there. Sometimes people feel that is more of a comfort level. Vera and I will stay around to do that. It happens to be about 20 after 4. These sessions really went a little bit longer than normal, so if nobody stays, we totally understand. They're very informal. You're welcome to stay, but we won't feel hurt if you say you need to be on your way. If you're on your way, make sure you drive safely. Vera, get up here. You are just as much a co-president as I am. She's the quiet one. She's the computer one. I'm the yucky one. So I think that's about it, except for we have wonderful news. Usually we're kind of late in deciding where the next conference is going to be. But Dr. Schleminski, who you heard this morning and is on our board, last December left Case Western University and went to the College of Medicine in Wisconsin, and he is going to host next year's conference. So we know a year in advance, so we're going to have big things going. It's going to be in September. We're going to aim for possibly this weekend or the next weekend before the weather turns cold and they start getting a lot of snow. So kind of mark your calendars for next September. You saw we had other people coming back. We had, I don't know, we should have had a show of hands how many patients returned. Several patients have been at two or three other conferences. So if that's something you can work into your budget and your time and your physical stamina to travel, we would love to see you next September 2013 in Milwaukee. So thanks so much to everybody for coming. Without you, there'd be no reason for us to have a conference. So we're grateful for everybody who's here today. And all those of you in the staff that helped put this thing together and ran ragged with me, thanks. Safe travels. Patients in the back, caregivers up here. In about 5 minutes, give those who are not going to be staying time. Thank you.